IVF cycle.
Fertility Doc's uncensored site on all things fertility doctors around America. Conceive or just planning. You're here to guide you every step.
Hi, everyone. We're back with another episode. I'm one of your hosts, Dr. Eblen Center, and today I am smart, silly co-host Ensign Hudson from the Texas Fertility and Dr. Carrie Bedient, Vegas. How are you guys doing?
Good. How are you, Abby?
I'm enjoying the you guys, but the weather's been nicer. The leaves are just good. And so one of my favorite things, and I'm sure you guys, leaves don't change in either place.
So our leaves that actually notice them more early December, we've got a lot of evergreen trees, but they're and stuff like that.
Yeah.
So then,
as opposed to dead oak?
The type of oak. So they are called live oak leaves.
They have moss. They tend to be really, really big tree. I don't know about Texas, but they had like moss hanging from them. They were like kind of this tree.
Yeah. And that we have in our area, but they change colors, but it happens for thinking winter. I like December because that's kind of and it's one of those things that you notice it and there's but it doesn't happen. Actually, things are getting a little September, October. Mm-hmm. And so looking better than it has over the But I love fall too. I do.
Fall.
I think it's just slower paced time that I can I'm driving. It's time to breathe. It's a very time of year, even finishing up my class. I'm doing, I got work and everything put together, but a year that I'm which I'm done with that. And season, you're going into my house. Yeah. It's like, I call it, it's a time that you can, I don't know.
Yeah. What about you, fall?
I also a little bit, even though it doesn't actually comfortable to be outside. I feel like you're rushing from one thing all day, cleaning up actually sit outside without, and I planted season here.
Oh, really?
It's on Facebook.
So I got a bunch of ladder that I put them in, shade plants and some of the marigolds to, supplement my pots for that. And it's sitting outside.
Phases like you are.
It's hard to think you're planting.
Yeah. This is like my favorite time to hold the big bush. It's beautiful, but for a while they last.
Interesting.
Yeah, now is the time that we will go and be able to enjoy it. And then fall baking, my favorite thing.
Carrie's favorite.
Carrie, you talk about apple pies. Hey, we're going to bring one out to ASR.
Sure, it'll totally there won't be any problem playing. It's only a 5 hour. Yeah, but I was thinking about I should make pumpkin bars with them today.
Oh, sounds pretty good.
Office and I fixed them. Well, that kind of stuff.
My favorite part, and so much so that when I get married in October, and in fact, so I leaves would be just at their peak, like what you were saying, Susan, and the only reason I picked earlier weekend was I met my husband when I was in Florida, so he's a huge Gator fan, close to Knoxville, Tennessee.
Ball games.
Yes. So that was a free week because I was a Tennessee fan. He was having it in my house in Tennessee, UT football game going on. So we did it on a Florida or Tennessee football game at their peak, but they still were pretty.
I have an October anniversary too for seasons change. Well, I take it back. I take it back.
I think that's a common theme with well, Susan, what are our listeners?
Okay. Thank you so much for taking my class. You guys are the best. After I got married, we struggled with abnormal, so they did a laparoscopy, a right rudimentary right tube. Through more negative, AMH was 1 point. Started an IVF cycle and fell surgery, a miracle. I came and never resumed to normal. 4 rounds of Clomid and conceived my son, 10 months of Clomid and failed IUI and a failed IVF, 1 immature egg. 300 to 25 minutes, 36 hours later, retrieval 23 millimeters. My from 10 to 6, respectively, my F6.8. AMH is, I take all things supplement. Should I come to terms, my doctor wants to try another, same dosages, and am I going into can levels? Thank you so much.
0.8. What do you think, Carrie? I the lever on the slot, every time you go through an IVF cycle a bit, and it's comes down to a bit, and financially, she's not at the end of the line if Susan's making a face though.
Only 1 mature follicle?
But is that the stem?
Sounds
like a dominant.
Sounds like I have 2 feelings about this. I'm completely wild about months of Clomid and Lesrar. Only did 1 IUI. Maybe you might want to try it.
But that's kind of water under the bridge.
No, but to me, that's part of those folks' thought process. It could, maybe there's I like the idea of trying, maybe not.
I do know that the doctor looked at her and is going to tweak it, but 0.8, there's something going through premature ovarian failure. That's good.
But if you have to make it, actually did it in an IVF,
right.
And that was a whopping 100, 225.
Yeah, that is a whopping dose. That's 0.8. You're right. I didn't hear that.
0.8 to 1.9 variable. I don't is necessarily
I don't think that's got anything to do with it.
There's an egg. I would give it another try.
Follicle count was
10 to 6.
And she got 6 to grow, but only one. I would probably try another, nothing to lose. And I have patience with cycles to get to good. And in some of those cycles, it's pushing like, I want to keep going. And I think we should move. And then I'll embryo.
Up until she got that bigger than the others. I mean, she had a good microfollicle count. So
I would probably go, again, I might consider try something a little bit different. The data shows it does not hurt.
Yeah.
Except maybe, but I think you can financially swing it. It cannot. Then I think grateful for what you have and put into it and say, that is a very personal decision. All right, I'm going to accept I have.
Mm-hmm.
That's
all right. Our topic of the day, and we know and what we don't know. And I would then about what does go on receptivity. So tell us what endometrial receptivity kind of go from there.
I like to just squirming.
Susan.
There is not it's a very vague topic. Some faith in doing and it is not a black and white thing.
And that's because, I feel like I have this a fair amount of time, like I have 3 heads because, okay, if my embryo transfer didn't work, if you think the embryo do to improve my endometrium, what do we, and there's just not that many. It's frustrating for patients to go on the internet and look at all the, all know are antiquated difference. So that's why I kind of vague. So it is, Susan, that we're even talking about.
Thanks. But very simply, that we can look at, which is the lining of we can potentially improve your chances of the simplest way I can say. The easiest place to start is just in my lap.
No pre-preparation for the idea that I wanted to talk about. So
everybody can agree on making sure that anatomic inside the uterus.
What do you mean by
structurally? I would say most have either an HSG before transfer. If they need one or the other. I don't like HSGs at the uterus because things like polyps ultrasound. So my ultrasound is definitely.
What kinds of things do you find on gram and HSG and when?
Right. So, like polyps, little ovaries, you might find some that are interfering with it have formed, potentially had a DNC in the past, adhesions that we don't have a great explanation. Abnormal of the lining of the uterus. If you have a very mild heart called an arcuate uterus, surgical intervention is, I think all of us, if hysteroscopy and even arcuate uterus, a normal contour, that should definitely, septum is fibrous, blood supply is the rest of the more severe things like a didelphic uterus, those correct. We work.
One of the things that concept of hysteroscopy, you guys, but I used to be when I would do a hysteroscopy and I would have either a clear saline sonogram and then I go in and do it, versus someone who had a couple of failed sites just didn't stick. Well, the data on endometritis. So our practice has started hysteroscopies on everybody just as part of their workup. But 1 in 5 or 6 women, and especially as we started out, referenced, okay, how many saline ultrasounds do we do a hysteroscopy without anesthesia? Out, done. And the abnormality, it's every 1 in maybe 1 in 6. 90% of women where their original photos from and there's lots of views and it looks there and there's extremely inflamed and none of that gets picked up. We started to do a lot more of because we just weren't picking it up and see down the line. We've just started this within the past or so.
That'll be really bullish too. Cause it's like when we find a polyp or something, a centimeter, it's kind of like, well, if it or not. And I lean toward doing hysteroscopy. Some people want to leave no stone unturned. But I go in surgically and I just see the polyp that's not very big. It's really worth doing it or not. If the patient and for me, it's worth doing everything that we can. But that study says.
I think a look at fertility treatment. Very rarely do we have this is absolutely what.
Yeah.
And a lot of our fertility. So we're looks like, and then we're maximizing. And by maximizing all those things together, those things may not have helped when you get all your eyes, why our OCD do. Mm-hmm. That's how and what Carrie was saying, I'm thinking of was almost showed that in some alien ultrasounds, but had transfers that were unsuccessful, had uterine time of hysterectomy was before consistently PGT cycle. I kind of manipulate saying, well, untested embryo successful if I'm much more quick endoscopy than in my career. Things like ERA, ACL 6
Now
and all that stuff. So punch back.
To ask Carrie that very question. Patient, she's had a normal history, 1 or 2 failed cycles, and the transfer went great.
So we PGT testing. We talk about the impact of trans. No, not all at once. In general,
Yes.
Like this is about the baby, not when people ERA.
What is the ERA?
A receptivity assay, and it's a month that you are not. You do it 1 month, you transfer the next.
Except in some cases, you do estrace. Whatever cycle you do in the next cycle, birth control pill, you do the birth and the biopsy in that cycle, a 2-month cycle.
Right. You pretend it's the real deal. Take your biopsy and you get it's not, you are receptive, i.e., do you transfer before that or after that, depending. I don't do that. I tell my patients is one key assumption which is that the uterus responds every time you do something. A lot of gestational carrier cycle. And so what I have of doing this, and this are patients as well, but gestation had successful pregnancies, don't have fertility problems. When they go through this priming, embryo transfer, well, what sees, we can see a lining that doesn't look dull, do it again, and the next month we see a different result. Assumption that the month to the next, like that's part of the reason why biopsies, the endometrial biopsy, and several, they kind of fell by the wayside. This is banking on that for month to month. And so for me to do it. And when you really look, it doesn't show a whole lot. And so for something that is both, I don't do it. We do cycles. We make sure that hysteroscopy, we do practice everything as easy as it can be, organized as it can be, shifted the window of, still be within the window of implanting it. But for the ERA data, because this is something that my partner and I have gone through times, it just bad. I really
all want to believe it. But
I haven't seen it in the data and I haven't seen them use it because it's but I don't fault
a little bit different perspective. Everybody, but I definitely, I have not without the ERA. When I first started, I had one person particularly transferred somewhere, but just could not, did the ERA, made the adjustment. And I've had, and some of it may also on when you do your biopsy, because different people have hours of progesterone exposure. Cycle does the endometrial is it measures the hour progesterone, and it makes a progesterone that you can't change what you're doing cycle to cycle. So in my practice, I don't use it for somebody has two that are chromosomally normal. I don't, but if it's full, they're definitely, and they've been pregnant. If I just did that next cycle, it is. You have some people in my clinic. If I wouldn't have ended up with those.
I'm kind of the same mindset. I agree with Carrie. Unfortunately, nice prospective studies and reproduce fall back on, honestly, sometimes when it looks good, when you've transferred embryos, the transfer's been easier, and they still don't get, again, patients looking across, we're like, what are we going to do different? Of insanity is doing the different result. And so I don't necessarily have stock in the ERA biopsy, something different. And means anything. I don't think if you keep flipping the coin, chance of pregnancy with each coin enough times, you're going to have the right one where you did the ERA biopsy, because I don't know what else to
do from the ERA. If it's most often, it's that you're 12 to 24.
Right.
I think it makes sense if you're hitting a wall. Yeah. So instead of doing progesterone, I don't think you need the ERA to do something different. Important is the type of progesterone it's getting. Is it precise? Do you have time?
Right.
Is she getting an adequate amount? Certainly there's a difference between oral methods. Oral is not a transfer cycle versus progesterone. There's a good couple months that progesterone is, so that always raises, because vaginal versus IM in the butt. The back feels like you've got the worst suppositories. It's like there's some, it's just gestalt, and I think we can change reasonably. You don't want to change so much that you.
Yeah. So test biopsy in a patient who has multiple.
There's other testing out there. Do it. I know there's testing.
Occasionally I will, which are cell adhesion factors, L6, that seems to be endometriosis, or at least that's present. It's bad for it to be present. So the problem with really no definitive what you should do for treatment. A lot of research in that area. Bruce led done research in integrins for a long. The studies that they've published, they've shown a bit of improvement and never goes away. But if we're treated with estrogen lowering drug, may have some impact of endometrial. And then the other drug that they treat with for about 3 months. And so again, the idea that this BCL6 endometriosis, and so the only way you can diagnose endometriosis, but some of this you may not necessarily need to do that endometriosis. And Carrie suggested this option is, and not everybody, but endometriosis on these cell adhesion factors, in controversial area in our field, and it's on that. So everyone had multiple repeated, has a history of endometriosis, commonly do that. once every 2 years or something.
On protocol for a prolonged period, I think helps. But
yeah. And I think that's that I just wanted to convey to one of your physician. So I'm just making this up. Is this really true? I've been in this field for unfortunately, there really has not been goes on in the endometrium when somebody gets, if we had more information about that, maybe make the next hurdle. And I think that's hopefully 15 to 20 years. That's what be on the endometrium, adhesion and help with. Now there's just not randomized. We're just kind of, you're sick. What have we done before? So let's try. No set in stone round. Somebody's had 2 or 3 failed. There are comments you guys would like to make?
Good.
All right. For joining us. Tune in to subscribe and leave us a review from you.
You can also visit to submit specific questions. All questions will be answered anonymously, so don't hold back. We also love episodes, what you want to hear.
As intended as a substitute for the advice. See you all soon. Bye.